It's a real privilege to be here, and particularly with this group of people on this panel. And it's a wonderful opportunity to talk about something that I'm very passionate about as a person and as CEO of Northern Health. I want to talk today a little bit about some of what you've heard from Diane, but from the perspective of what is happening inside a health authority. And the innovation that I want to talk about is the implementation of a system of integrated health services. And the way we frame that is built on a foundation of primary care in our health region. And I've posed two questions that I tried to focus on as I shaped this presentation. I want to highlight the three areas that have been really important to us as we've embarked on this journey. And it's a journey that started really when Northern Health was formed. And much of that foundational work in the early years was really important for where we are today. I think since I've been CEO, we've spent a lot of time on defining our vision for our organization, certainly in alignment with the Ministry of Health, but for the North, for the people who live in the North. And that clarity of vision has been critical. The second piece has been around process and really articulating clearly who we are, how we are going to be in the work that we do, and then building trusting relationships. We are doing this for a purpose, and it is for improving the outcomes of the people that we serve in Northern British Columbia. But focusing on these things, I think, has been critical. Northern Health is the northern two-thirds of the province, so the green part of that map. We are rural geography. We have responsibility for acute care, community services, mental health, public health, home and community care. We have an interdependency on the primary care system, physicians, and the physicians that serve the region. We also have an interdependency with the academic institutions in our region, other organizations. We're very close to our communities, so the municipal leaders across our region are critical to the work that we undertake. And all of that leads to the kind of complexity that Diane described for you. The important parts of the journey that we've been on, I'm going to try and articulate those for you now. And I'm going to start with leadership, because leadership has been absolutely one of the most important things in our organization, right from governance through to the leadership at the front line for how we've embarked on this work. And it's about engagement of leadership in the day-to-day work of the organization, but with a vision in mind. So really, the leadership has had to engage at two levels. How do we think about where we want to go, what our vision is for the future? And then it's about some really hard, difficult work with your sleeves rolled up on the ground with people, talking to people, having difficult conversations, good conversations, but often difficult, and the kind of thinking that needs to go along with that, and then being present. Our board has set out a strategic plan for the organization. This engaged a large number of people across the health authority, both externally and internally, and has really set the stage for the way in which the organization has worked. And you'll see that those words, partnership with communities and organizations, as being front and center. We have 4 strategic directions, and again, these are in alignment with the broader health system in British Columbia, but these strategic directions have really set the stage and positioned the organization to work on integrated and accessible health services built on a foundation of primary care. I'm now going to describe for you some of the processes we have undertaken. It's a little difficult to do this because it's not linear. It is messy. It's like the bowl of spaghetti. And the way I've decided to approach this is just to describe some parts, some elements of what has occurred. And you need to know they're not in sequence, and they weren't linear, they were always iterative. One of the things that happened in the early part of my time as CEO is that we embarked on what we called a collaborative, and some of you will be familiar with the IHI collaboratives, focusing on chronic disease, focusing on the work we wanted to do in primary care. And we had a closing congress. And at that closing congress, there was about 150 staff and physicians in the room. And they asked the organization, the executive team, and some of the board members who were there to come back with a vision for the health system. They wanted to understand what our perspective was, what end in view did we see. The executive team went away, and this is what we produced after 2 months of really hard thinking and dialogue. And the important components of this are the person and families in the center. The primary care home is wrapped around that person and family. It is about the work that happens in primary care practices as well as the interdisciplinary team. And it's within the context embedded in a healthy community. The implementation process required that we really understood the context that we were going to embark on this work. And I've just put down some examples of what is in that context. There are other things, and this has evolved over time, but we've continually had to be attuned to what that context is. And the importance of that is has been related to timing of action, when we do something, when we choose to take action. It has also been really critical in terms of the support that we provide to the implementation teams in our communities as they try to navigate this context, which isn't always straightforward. In fact, never is straightforward. The other thing in the implementation process that has been really important is determining what kind of a resource team needs to be put in place, defining those roles and responsibilities carefully, and ensuring that the right skill set is brought together, and that we have an implementation structure that enables the dialogue and an iterative process to occur, particularly related to that vision, process, and relationships. Where do we talk about how we are going to do that work? We also articulated an implementation plan. We organized the work in 4 streams, and you see those there. And I'll talk a little bit more about some of those, but it was very important for clarity for people to understand the streams of work that would be undertaken, what resources were available, and how they were going to engage with that. We did make the decision not to try to do this work across the entire region, but to choose 3 communities that we would, what we call prototype, different from pilot. Not sure if that word is exactly the right word, but it's the word we've chosen to use. We've chosen 3 communities, Fraser Lake, which is a very small community, Prince George, a large community, and Fort St. John, which is one of our medium-sized communities. And we've learned some things as we've been doing this work in these communities, as we've engaged with the communities, as we've engaged with patients, as we've engaged with our staff. We've learned about balancing the regional vision with local action. We've learned about the importance of the presence of leadership to help make it happen. And we've also learned that this is absolutely not about rolling something out or driving something out. This is about helping something to emerge and happen in a community. And what that takes is a tremendous amount of engagement and dialogue and building relationship with the people we serve. Some of the patient journey mapping we've done, listening to patient voices, incorporating patient voices along the way, working with communities to understand their perspective of their needs, not just what the data says, has been absolutely profound in terms of the aha moments that it's produced for those involved in the process, and has led to action and has changed some of the assumptions we had about the action that we would be undertaking. We have been determined to shape this within the context of a healthy community. And to do that, we've had to engage vigorously with communities about what they understand their needs to be and where they see their priorities. And this started with a consultation process led out by our board a couple of years ago on their understanding of primary care and primary health care, and their understanding of how they could contribute to that. And from that, we have 6 communities initially that engaged with us, physicians, health authority staff, municipalities, and other organizations to look at their communities and the health of their communities. That has now expanded to 13 communities. We've also done a lot of work around seeking to understand our staff. What are they saying about what they do every day? What kind of workarounds occur? What kind of duplication of services are they experiencing? How have we matched services to people to services? how have we understood what the needs of the people are in the community and how we've built our service delivery system. Tremendous learnings from those kind of conversations. We've used some very structured processes to do that, such as system mapping. This is just an example of one small aspect of some of that work. And we've also had the opportunity to bring data together from Northern Health and physicians who have opened up some of their data from the scorecard and the EMR that we use in the North. And we've been able to pull that together and really understand the people that we serve and how we've developed our service delivery system. And again, this is leading to action that is maybe a bit different than what the assumptions were at the outset. As Diane mentioned, there is an evaluation process provincially, and we have purposely built ours using a developmental evaluation, which is alongside of the implementation process in the 3 prototype communities and beyond, and provides real-time feedback. And as a result of that, there have been many course corrections that we've been able to take right at the time that the issues emerge. We also have a research project, and the title is there for you, that we've embarked on with UNBC that is looking at the entire system change that we are trying to undertake. And again, feedback is coming from that to the teams as we're moving forward. There's a interview process that occurs on an annual basis of community members, physicians, and service providers and managers. And many of those people have said how profound just answering the questions has been in the research process in terms of their own insights. There's a poster actually on this research that Martha McLeod and Suzanne Johnston from the North will be at later today. So as I said at the beginning, we're on a journey, and we're at the beginning or middle, I'm not exactly sure where we are in that process, but we still have a lot of work to do. I'm not sure if this will ever really be complete. We recognize that it's a longitudinal, long-term journey. We also recognize that the changes that we're looking at in the 3 prototype communities will continue to evolve. We also recognize that there's going to be a need to normalize or routinize some of the changes that we're putting in place, and it may require reallocation of resources ultimately. We also are thinking about the next set of communities and what we've learned so far and how we're going to implement this next phase. And then understanding the acute care system differently. We often look at the healthcare system through the lens of acute care. How do we reverse that and look at acute care from the lens of what we're doing in the community? So here is my final slide and the learnings that we've had so far. The need to balance that articulation of the vision versus enabling a shared vision. The need for dialogue versus the need for action. The engagement in a process versus structural solutions, which is very often where organizations go. And all of those things are needed, but finding the balance and the timing is critical, which requires us to be attuned. Being attuned, paying attention to timing, attending to the tensions and challenges that emerge, and leadership presence. That's how we are able to be attuned, is because we're present. And then recognizing that we are striving for success in the long term. We're not looking for success. We'd like to see success in the short term, but the real success, we believe, will be in the long term. And then this last one, I think we're still learning about this, about how you build external relationships and partnerships by acting together, and through that create synergy between those partners, which in turn enables mutual change, not just in Northern Health, but also in the work of primary care practices, within the academic institutions, and so on. So thank you very much.